everyone, and welcome. I'm Jackie Mayer, Vice President of Credentialing and Managed Care here at MDeverywhere. MDeverywhere provides cloud-based revenue cycle management technology combined with expert back-end billing and credentialing services to physicians. I'd like to thank you for joining us today. We value your time, so we'll keep today's webinar to just 30 minutes. Our topic, how to negotiate managed care contracts. Quick housekeeping note before I start. If you have any questions, type them into the questions chat window on your control panel as you think of them, and we will follow up after the webinar. And yes, everyone will receive a copy of the recorded webinar as a follow-up to today's presentation. So let's get started. Here at MDeverywhere, in addition to a full suite of practice management services, we provide credentialing services to physician practices of all types across the country. A common request is, when do I get to renegotiate my plan contracts? Or, my colleague is getting better rates than I am, so how do I get an increase? After our session today, I hope you'll walk away with a plan to evaluate and hopefully negotiate some of your contracts. Or at the very least, look at a new contract with a more discerning eye. Prior to forming a credentialing department to assist providers with their plan enrollment needs, I held management positions with large commercial plans, and my focus was negotiating physician, ancillary, and hospital contracts. I had access to finance and data specialists who could analyze the impact of each dollar increase in a per diem or a procedure code during negotiations when we opened up a contract. Opening up a contract meant we were negotiating. More often than not, our providers across the table could not mine the data as effectively or did not have the data available to them. If you're asking a plan to open up your contract, be prepared. Health insurance is a business, but so is healthcare delivery. Approach your negotiation as you would any major business transaction by researching and being prepared. We all know too well that in our industry, change is the only constant. Changes brought about by the Affordable Care Act are reshaping the medical community by creating new alliances, delivery systems, and payment strategies. However, whether you're evaluating a contract for your solo practice or in conjunction with a large group of which you are a part, the contract evaluation and negotiation processes are similar. So, your first takeaway is that provider contracts contain many common elements. Although you may be negotiating with a health plan today, tomorrow the entity across the table may be a plan, a hospital, a cooperative, an ACO, or any number of configurations yet to be determined. A few years ago, during more feel-good financial times, my providers in metropolitan markets were calling and telling me that friends were dropping out of plans because they were fed up with low plan reimbursements. I'm terminating, and they'll have to pay me full charge as a non-par provider. I was in the awkward position of letting them know that although they had a great practice with a loyal patient base, when patients have the choice of staying in-network with low co-payment or going out of network and paying deductibles, co-insurances, or even your full charges, loyalty can fly out the window fast. Patients are reluctant to dig into their pockets when they can go to your colleague and pay only a $20 copayment. If you drop out of a plan, please assume those patients will go elsewhere. If they have nowhere to go, listen carefully to the rest of this presentation because you are in a position to negotiate. Say you're a cardiology group in a suburban community with a couple of large employers in town, neither of which offers, for example, Cigna. You don't have much Cigna volume, and you really don't like their rates. You terminate your contract. Well, January rolls around, and Cigna has just become the insurer for one of these employers. The modest impact you expected has now become devastating. I always advise practices consider all of the what-ifs and speak to the plan before doing anything drastic like terminating a contract. The recurring theme you will hear today is that your success in engaging a health plan in negotiations or in ultimately winning better terms or rates will depend on your local market as a whole, as well as your value to the plan as a participating network provider. Today, we'll cover some managed care contract basics. We'll provide a strategy for reviewing your current contract status, both language and rates. And finally, we'll look at negotiation strategies. Whether you're successful will depend on a number of factors, but it doesn't hurt to ask. Let's start with some basics. Health networks or health plan participation involves both credentialing and contracting. You'd be surprised how many people don't realize that. Credentialing is a review of the licensed practitioner's qualifications against the network standards for participation. The credentialing process culminates in committee review and an effective date for approval. In larger plans, credentialing is handled by a specialized team and is often centralized. Credentialing is repeated every 36 months, and as long as re-credentialing is successful, the provider remains in the network. Between credentialing cycles, plans will be checking monthly to ensure that no network providers have been sanctioned by Medicare or Medicaid and that their licenses remain in good standing. The plan will certainly reach out to you for re-credentialing. However, if you're being paid under a standard or what we call boilerplate contract, you can be sure you will not be approached by the plan to renegotiate your contract. Contracting is the written agreement which defines the terms by which you will provide services to members and the method by which you will be reimbursed for your services. Plan contracts must comply with regulatory requirements as well as those of employer groups who are the plan's customers. To become participating, your contract has you agreeing to abide by policies and procedures, most of which you have never read and probably don't even know how to access. From the plan's perspective, they're protecting their members' access to care and ensuring that when members follow the rules, they will not be charged more than is appropriate. Contracting may be handled by the local provider network staff in smaller plans or by specialized network management or contracting teams for larger plans. Increasingly, contracts are signed electronically or e-signed. Make sure you keep a copy of those. No matter how large a plan is, contract negotiations still remain local, even for national commercial carriers. States license managed care plans, so contract guidelines vary by state, as do the products offered from market to market. Providers, are you reading your contracts? I know some of you do, but if you don't, I can't blame you. I'll challenge you to read, though, just one to begin with. Take your largest volume payer. If 30% of your income is coming from one source, you should really know what your rights and responsibilities are, correct? Okay, so part one, the anatomy of a contract and what is negotiable. Contracts consist of A, language, or paragraphs or clauses, which spell out the obligations of each party. B, references to other documents not detailed in the contract document. And finally, C, an attachment which contains rates or references to rate schedules. First, the contract language. As you look through some contracts, you'll notice they all look somewhat similar. Plans may have flexibility to alter some language, but very little or no flexibility to change or delete language required by states, regulatory authorities, federal government, or accreditation bodies such as NCQA. Non-negotiable contract language can include member holds harmless or balanced billing restrictions, confidentiality provisions, many relate to HIPAA, and continuity of care language. For example, continuity of care language ensures that patients can continue to receive care, your care, for the duration of their illness or episode even after the contract ends. Make sure you're clear as to whether you'll need authorizations and confirm what you will be paid for providing care after the contract ends. This particular language is clearly for the patient's protection. However, many contract terms are designed to give the plan control over the vast majority of administrative processes and payments. Keep in mind that a health plan is always looking to maintain stability of both medical expenditures and the provider network. The contracts are designed to do just that. Claim filing deadlines, retroactive member eligibility takebacks, and overpayment processes should all be understood. If you feel a contract provision is unreasonable or you cannot abide by it due to administrative or financial burden, request that the language be stricken or suggest alternate language. The plan will let you know if the language is mandatory or if a requested change is unacceptable. Negotiators are very familiar with the sections in the contract that usually draw objections. They will be ready with a firm no or alternate language their attorneys or executives have approved. There's usually a section called Obligations of Provider, and this section is somewhat longer than the Obligations of the Plan section. Are you surprised? Managed care contracts are lopsided. They always have been. However, they really should be fair. Term and termination provisions spell out how and when each party can end the contract. Usually there is a without cause provision and a with cause provision. If either of you brings forward cause for termination, such as a breach of the contract, unless there is a patient care concern, the other party will have the opportunity to correct or cure the breach after notification. Most contracts are evergreen. This means they automatically renew. I'm surprised by how many providers do not realize their contracts are evergreen and not open for periodic renegotiation. Again, network and financial stability is the rationale behind evergreen contracts. Next, plan policies and procedure references. We touched on this before. Even though the policies and procedures, or P&Ps, are actually not in the contract, you're agreeing to abide by them. P&Ps change too often and are too lengthy to include in the body of a contract. P&Ps reference may relate to claims processing, medical necessity, medical policy, and utilization or quality management. You should request access to P&Ps if they're not made available. As a rule, plans will not negotiate changes to their policies and procedures unless the request comes from a group of such significant size and value, but even those changes are rare. There is nothing a plan is more reluctant to do than allow exceptions to claims or administrative procedures. Manual processes are expensive. Finally, rates or fee schedules. Reimbursement rates by CPT-4 code, especially those relevant to your specific practice, are not likely to be listed in managed care contracts. Commonly, rates are based on A, a percentage of a published fee schedule, such as Medicare, B, a percentage of charges, or C, the plan's proprietary schedule. If you can calculate your fees, do so for your common codes. If you cannot figure out your reimbursement, request the information from your rep. As a participating provider, you do have the right to request and receive fee information. Ask for fees for your top CPT-4 codes or a sample schedule for your specialty. Keep in mind you may have to request multiple schedules from a plan if they have several products. One thing to remember is that the fees are all inclusive of co-payments and co-insurances. If you're not collecting your patient responsible dollars, you're giving the plan a far deeper discount than you can afford to do. Collect your co-payments. Does the contract include all products you would like to accept? Any products missing or excluded? You need to ask why. Remember, plans are paid premiums at vastly different rates from Medicare, Medicaid, employers, etc. So you can expect that your fees can vary by product. Also relevant is the plan's policy on notification of changes in fee schedules. Plans may have an obligation to notify you of material changes in fees. What exactly is material anyway? You really should ask the negotiator. Determine what is right for your practice with regard to reimbursement. You may be asking for an across-the-board increase or only adjustments for specific codes or services. You may be capitated for HMO services as a primary care practice, and you're asking for fee-for-service payments instead. Have you considered first asking for certain procedures to be carved out of your capitation? It doesn't hurt to ask. Know your volume by procedure codes, so you're focusing your energy on rates that are meaningful to your practice. I like to create a grid with the key language provisions for each plan. Illustrated here are actual plan terms, however not for Cigna or United. That's just an example. In the first column, list your plans. Across the top, list the contract provisions you consider meaningful. I would certainly include the effective date of each contract, products or lines of business covered by the contract, claim timely filing limits, reimbursement methodology. Actual rates are rarely in the contract, and these little handy grids don't have enough room. You should have a separate spreadsheet for that. Claims appeal guidelines, term of the contract, and finally termination provisions should the relationship go south. The average practice signs 15 to 30 contracts, but some are more meaningful to your practice than others. Focus on them. But it doesn't hurt to have a grid like this handy for your front desk staff, your billing staff, anybody who may need to just quickly look at what those terms are as far as timely filing, etc. Next, prepare your rationale for negotiation. First, know your value. Look at your request from the plan's perspective. Why should they pay you more? They already have you. Your specialty, geography, and the size of your practice, and any special services you provide will help your argument. Plans are most interested in controlling medical costs and retaining employer groups. Are you a PCP practice with a large panel? Losing a PCP or a PCP group is never something a plan wants to face. Does your group offer urgent care after hours? This is desirable, as is any other aspect of your practice, which will reduce the utilization of more expensive sites of service such as the ED. Perhaps you're the only pediatric cardiologist within 30 miles or the only specialty group at a participating hospital. Search the plan's web directory and do some research. Know your value. Second, time your request. Plans have budgets and premium rates need to be finalized for approval each budget year. Anticipating next year's medical costs are a big part of the process for health plans. Put in your request early, say this time of year. Expect that the process may take some time and will require persistence. Be persistent and follow up frequently, but always remain professional and polite. You're asking for an increase in reimbursement, so you can anticipate pushback and maybe some stalling. If you're not receiving a response at all or wish to escalate a no response, ask for the director responsible for contracting. Next, make sure you're getting to the right person. Ask if the local contracting team has the authority to negotiate language or rates. Is the local medical director in a role where he or she is the decision maker? Negotiation is local, just like we said, and every market is different. The contracting staff should know the market and will certainly have the resources to analyze your value in the marketplace and pass along your request to those who can assist you. Now, you know your value of the plan, you have the right person engaged, and you've submitted your well-timed request for language and reimbursement changes. Some negotiation tips. Be prepared to compromise. Be creative. Be flexible. If you can't get across-the-board increases, maybe you want to focus just on E&M codes or high-volume surgical procedures. If you can't get all you want this year, offer a multi-year proposal. Maybe you can agree to keep your panel open if you're a PCP. Again, network and price stability are important to plan. Beware the ultimatum. If you're not prepared to terminate the contract, do not threaten to do so. Is your practice better off being non-par with this plan? Will your patients flee to a par provider after you term? Are you willing to risk not being able to get back into the network? This does happen. Again, your value to the network and value to the plan, value of the plan to your practice need to be known. If you're successful, also keep the terms of your negotiations strictly confidential. Never discuss your negotiated contract with colleagues. Plans take this very seriously, and every practice is unique in terms of their value to a plan. You do not want to violate your contract and risk termination if you or your group's contract by sharing the terms or rates negotiated. Smaller practices can tackle negotiations themselves. However, now that you're an expert, but for larger groups, here is a guide to the types of resources which can assist in the analysis and even negotiations. Locally based consulting or healthcare legal firms with a proven track record are your best bet. You have heard it before, healthcare is local. A reputable firm will be upfront with you on your chances of success. Request and check references. You work hard for the financial success of your practice. So if your expectations for a negotiation are at odds with your market's realities, you really should be told this up front. If your group is of significant size, such as a hospital-based faculty practice or IPA group, you'll want to look for experience in representing similar-sized groups. Consulting fees can be thought of as an investment should you be successful in negotiating more favorable contract rates and terms. Be aware of your ability to negotiate as a united force with other providers. It is not permitted unless you have a formal association that can pass the test as an integrated delivery system. Well, we hope you have found this information helpful. I'd like to take just a minute to talk about MDeverywhere for those of you who may not be familiar with us. We provide cloud-based revenue cycle management technology and expert back-end billing and credentialing services. We provide service to approximately 3,500 physicians nationwide, ranging from solo practices to mid to large-sized group practices up to faculty practice groups and hospital organizations. We provide our clients with an online patient portal, Patient First, which keeps their patients in touch with their physicians and provides an easy way for patients to make online payments. And I'm particularly proud of the top-notch credentialing and enrollment services we provide. If anyone would like more information about MDE's revenue cycle or credentialing services, do not hesitate to contact us after the webinar. That concludes our presentation for today. We'll follow up on any questions submitted after the webinar. A link to today's recorded presentation will be sent via email to all attendees. We'll be hosting the same presentation in the near future, so we'll let you know about that. Thank you for joining us today, and remember, it doesn't hurt to ask.